Hey everyone, this is part 2 of our discussion with Dr. Katharine Monk. It picks up right where we left off in part 1. Welcome back. What should we think about this? I mean, if a child, a baby, a 2-year-old, a 4-year-old, a 10-year-old has a more or less active amygdala, is that who cares?
Wow, it's another great question. So, and an important one because for 2 reasons. In developmental research, we think about plasticity. The brain is, in its development, is plastic, meaning that nothing is set in stone, nothing is permanent. There are going to continue to be influences that shape it throughout development. So we really need to remember that this is a brain getting shaped. And just because we're seeing these 2 early indications of a certain trajectory, a path, a future for development, doesn't mean it's set in stone and that we necessarily know what it means. What we're seeing is that this is a brain, these seem to be brains getting shaped differently based on mother's depression and anxiety during pregnancy. And there may actually, theory goes, be something that from an evolutionary perspective might have been advantageous about this. And that is that the mother would potentially, with her anxiety, for example, want to communicate to the fetus by mechanisms we're still trying to understand, possibly a stress hormone, cortisol, crossing the placenta, influencing brain and behavior development in utero, to say it's a dangerous world out there, be ready. I'm anxious because it's dangerous out there, so get prepared. So some of the thinking is that this brain behavior differences you're noting, it's not necessarily that we think they're bad or good. They may be accelerating development to be aware of the future out there sooner and be prepared. And what people often think about now, and it's so important in terms of raising children to think this way, is the match between that developing organism and the baby's environment. And that can be on a macro level, meaning, are you anticipating those bears in the woods we all learned about as children, learning about fear and how the brain works? Or are you in a 21st century classroom? It can also be on a more micro level. How are you and your parents, are you a very good match, and how to make you even a better match to continue shaping your brain behavior development? For example, a baby who's very reactive and a parent who's extremely calm could find it annoying and not understand their baby. Or a baby and a mother who are both extremely reactive and anxious could make each other more uncomfortable and less well regulated as a unit.
So I know that you have a clinical practice and you're also running a program that is working with pregnant women and then the first couple of years after their babies are born. Can you say a little bit about that and how you're seeing those dynamics play out in that work?
Yes, absolutely. I guess what I will say is more from a years of clinical experience, that it's so important to bear in mind this idea that I'm focusing on women right now, on mothers, and being a little biased in that, but that every woman learns their baby, and even if it's a second or third baby, because all babies are different. And again, that in some ways this is already happening in utero because the woman is shaping that baby. But they are a unit, and in clinical work, I try to support them reading each other's cues to optimize how well they fit each other. In our clinical intervention, and I can't quite say it's a program yet because we have preliminary data and we're about to start some new large work with a lot more women, but we've developed an intervention that starts in pregnancy and then goes to the postpartum period, and it's for women at risk for postpartum depression. And one of the biggest risk factors for postpartum depression is being distressed in pregnancy, so having anxiety and depression. So we're really targeting it in pregnancy. It's called PrEP, which stands for Practical Resources for Effective Postpartum Parenting. And it's a very brief intervention, just 5 sessions. And we have 3 foci. How to optimize baby regulation and feeling competent as a parent, some mindfulness skills, and then what we call psychoeducation or information. So starting with the latter, it's what to expect from your baby. The mindfulness is the kind of mindfulness we all many of us at least, try to practice nowadays to help ourselves find calmness and a way to deal with challenges. And then probably the biggest part of this is engaging women where they're at, even in pregnancy before the baby's born, which is wanting the best for their baby and wanting to feel that they have all the tools that can help their babies sleep as best as possible and fuss and cry as little as possible while still communicating. Part of why we've oriented PrEP this way is to reduce stigma around getting behavioral health services. So it's very much focused on the baby and you, and you the mother. And we are approaching the risk for postpartum depression as something that happens to a mother and her baby. Because not only the research I've described to you indicating that the fetus is being affected, but there are decades of research showing that postpartum depression dramatically affects children's development, particularly cognitive and emotional attachment development. So it affects both of them. So our approach starting in pregnancy is meeting women where they're thinking, which is often very much about their baby as well as about themselves, and reducing stigma by orienting this intervention for both of them and away from mental health per se. And we've had very good results so far. We have 0 attrition, which is amazing for behavioral health interventions. It's only 2 in pregnancy, I should say. We visit them at birth. There's a check-in phone call, and then there's a 6-week session. So we've had 0 attrition when we've run this, and we've cut the rates of serious postpartum depression in half.
And what kind of women are these?
That's a great question, too. We really do know what are risk factors for postpartum depression, but they're probably not as well advertised as, say, risk factors for breast cancer, and they should be. So past depression is one of the biggest, meaning in one's life, being depressed during pregnancy, low social support, poverty. The rate of postpartum depression is about double in a poverty sample, so up to almost 40%, where it's 10 to 15% in a non-depressed sample.
So what are the primary risk factors that you've identified?
Well, I should say that this has been known for a while, so it's not just me identifying risk factors for postpartum depression. And just to emphasize that we all in the public probably know risk factors for certain cancers better than we talk about the risk factors for postpartum depression, or frankly any depression, even though they are well known. For postpartum depression in particular, depression in a woman's life previously, depression during pregnancy is a huge risk factor for postpartum depression, low social support, ambivalence about having the baby, problems in the partner relationship that is led to the pregnancy in the first place, and some data indicating a difficult relationship with one's mother. Those are some of the major, but I really also want to emphasize that while the rate for postpartum depression, I mean, it's really pretty high, 10 to 15% of women, and you can compare that to, say, gestational diabetes, which is about 3 to 5% of women. This is way higher. But when you get to a poverty sample, it's almost double. So the rates of postpartum depression in a poverty sample can be as high as 40%. So it's very, very high. The data we've have from our preliminary study of this was not a poverty sample per se, so it was really across the board. But all of the women met criteria for being at risk for postpartum depression, and we cut the rates in half of their actually experiencing it. So we're really optimistic about working with another group of women.
So there was a study done just in the last couple of years looking at the social and emotional readiness of kindergartners entering the Baltimore public schools. They followed those kids through 4th grade, and they found that kids who were assessed as not socially emotionally ready in kindergarten, meaning they had trouble sitting quietly, they had trouble following directions, they had trouble getting along with other kids, that those children were much, much more likely by 4th grade to be behind academically, to have been suspended or expelled. The other thing they found is that about 50% of the kindergartners entering the Baltimore public schools were not socially, emotionally ready to be successful in kindergarten. So probably the predominant policy response to looking at that, a lot of the kids entering the Baltimore public schools are disadvantaged kids. And what we're seeing is if they're not ready for kindergarten, they're going to have trouble as they're going through school. So one of the predominant responses to that is starting school earlier, sending children to pre-K to help them get ready for kindergarten. What you're talking about makes it sound as though there are places to be focusing much before pre-K, and I'm wondering what your thoughts are, based on your research, based on your work with these women, what your thoughts are on the children entering kindergarten not socially emotional ready. Are any of these pieces fitting together for you?
Absolutely, and I wouldn't want to in any way be saying we shouldn't also be providing support and intervention later. But I do say that our data and that coming out of other labs suggests that we can also be doing much more earlier. The data will hopefully someday let us know that because I hope we do get to do this, if we do more earlier, and I'll tell you what I mean by that, might we not need to do so much later? And so what would that look like? It would, in my view, look like a big public health campaign around the importance of maternal mental health. And I acknowledge that I'm focusing on women right now, but it is, after all, women who become pregnant. And so that we attend to their mental well-being, their behavioral health, as much as we do to their physical well-being. At least for most women, they do get adequate prenatal care. And that we would also, in that first year and two, the first postnatal year or two or three, really be thinking about helping women and their families having support for raising this child, and much more awareness of what our data is suggesting, and I assume we'll continue to have these kind of data coming out and it will get refined, that what a woman experiences is what the fetus is experiencing, that there is this phenomenal brain growth going on in utero. And so isn't it just obvious to think that we need to be attending then to that baby's environment, the mother, while that brain is developing in utero, and then the first couple of years of life around support for the woman and the family, so that they can be, I'm sure you know this work, all the serve and return and the engagement, the cognitive development and the emotional development that happens through relationships.
So the interaction, so you're talking about supporting, making sure that women are understand the importance and are kind of psychologically able to engage with their very young babies. Right. Are you seeing in your research that that's something women have trouble with?
Well, certainly if you are in your pregnancy and you're feeling very ambivalent about having the baby, or you've had a tragedy in your life that's on top of a significant amount of stress, or you're depressed, and this is, another time in your life when you're having a significant depression, already, and the bond with a baby starts when you're pregnant. I actually had a patient say to me the other day who is unfortunately at grave risk of losing a baby with a genetic defect, and she emphatically said to me, "But you're a mother when you become pregnant." And so the experiences you have, and already the preparation for that serve and return once the baby comes out, and of course early on it's even more basic than serve and return, is starting in your mind and of course in your heart when you're pregnant. So if you're feeling very depressed and overwhelmed, the sense you have of this baby coming is already overshadowed by that. So we need to be providing women the support they need and the understanding that their experiences are affecting their baby, and before the baby's born, and how can we provide support for everyone and education.
So, well, thank you so much. This has been absolutely fascinating, and I look forward to following your research as you continue to work in this area.
Thank you so much for having me. It's been really enjoyable.
Hey everyone, that's the end of our discussion with Dr. Katharine Monk. Thanks very much for watching. As always, let us know what other topics you'd like AAI scholars to cover on Viewpoint, and to learn more about early childhood development, check the links in the description below.